morning, everybody, and welcome to Health Talk. I am your guest speaker, Dr. Niru Prasad, with my background in pediatrics, emergency medicine, and urgent care. The theme of my health talk today is by a practicing urologist Amy Brott, and she's going to elaborate our viewers about the menopause. This is one of her specialty. So joining us today is Amy Brott, a practicing urologist. Good morning, Amy, and welcome to my show.
Thank you. Good
You
morning.
are in such a demand. Your
you,
field
yes.
is in such a demand. So before we start, can you give your introduction to our viewers?
Yes. So
I know you have done a lot of things. I was reading through your CV and all that.
Thank you. Yeah. So I'm a practicing urologist, and for about 20 years I was in just general practice.
Okay.
And then recently I left general practice to start a concierge telemedicine practice that focuses on women in menopause and also for men and women with sexual health or hormone management in a more concierge type model, so I can spend more time and really get to know people and not be limited by short visits.
Right.
Yeah.
So you have basically it is a telehealth thing that you are involved with now. You enjoy doing it, Amy?
I do. I really enjoy, all through my career, my favorite thing has been getting to know my patients and spending time with them. And so being able to do it in a way that I really have unlimited, well, not unlimited, but, a lot less limited. I don't have to fit things into 15 minutes. It's really enjoyable to get to know people.
You got to know people. So, Amy, the first opening question, as you had mentioned, given to me, how does a patient know if they are in menopause?
That's a good question, and a lot of times I talk with people, they talk about menopause. Are you in menopause? Are you not? And really menopause is just a moment in time.
Right.
The definition of menopause is actually when a woman has had 12 months without a period.
Right. Yeah.
After that is postmenopause. So it's really just that moment in time.
Okay. So this is what it is, menopause. You have to be 12 months.
12 months. And then there are, obviously there's surgical menopause, there's other situations where, it may not be defined that way, but that's the general definition. And that can happen for women, over a range of ages. Average age is around 51 or 52, and then we still have, what we call premature menopause or early menopause, premature being before age 40 or early being between the ages of 40 to 45. And so it really, can happen over a range of time period. There's not one age that people expect it.
So basically it is past 50, 51. If you didn't have periods for one whole year, then you consider it. And then how does a patient, does they have to wait before they go post-menopause hormone? Do they go on hormones?
No. So one thing that a lot of women struggle with, and they don't even always know that they're struggling, is the period of time called perimenopause. And perimenopause can be 4 to 10 years. It can last for a long time. And so, during that time period, women may be having regular cycles. They may be heavier, they may be lighter.
Right, weight gain, depression.
Yeah, and so they can have a lot of the symptoms that you think of with menopause occurring during perimenopause, and it's extreme fluctuations in the estrogen and progesterone that cause those symptoms. And so we can treat people before they've met that criteria of being in menopause, and so many women need that, and that's where a lot of women don't get that care.
So most important thing for our viewers to know is that do not ignore the period of perimenopause.
Absolutely.
That is 1 year before the real thing happens.
Well, it can actually
with
be
the treatment right then.
Yeah, it can actually be 4 to 10 years. It may not just be a year, so it can be a lot earlier.
A lot earlier.
And people
right,
don't
yeah.
expect it. They think they're too young. They're 40 years old. They don't even have menopause on their radar.
Exactly right. I see in the emergency room or urgent care this 40 years old, women, with all those symptoms of shortness of breath, anxiety, flushing, face flush. But I think, those are too young age. But then before they did not have a good differentiation between perimenopause and menopause. Yeah.
And we really do rely on the symptoms. That's a big thing, is that, women will come in or their doctors will say, let's check your lab work. And the labs fluctuate. And so there's not really good labs. We don't decide treatment based on lab
No,
work. We decide it on
right.
symptoms.
Right. So this is the problem, Amy, because there are no lab, there is no diagnostic worker, you cannot get the X-ray, you cannot take the lab. So basically, it's just a symptomatic treatment, right?
Absolutely, yes. And that's why, for me personally, I like being able to have such a long time with my patients,
Right.
so that I can really spend the time to ferret out what's going on and figure out what symptoms are bothersome.
What
and
symptoms, yeah.
what bothers one patient does not necessarily bother another patient. And so it's really figuring out for each
so
individual.
So now, do you think do all the women need the hormone therapy,
No, I never.
hormone replacement?
Yeah, so menopause hormone therapy is, I think, such a benefit, and there are so many benefits to it. And we see decreased osteoporosis. There's decreased all-cause mortality, decreased diabetes, improvement in brain fog, joint pain. It's more than just the hot flashes people think of. There's so many benefits. That being said, women make their own choices. Women are smart.
That is true.
I think
is
that
true. They make their own choices.
we need to educate them and let them know the benefits, possible risks, let them know how it may affect them. And
Right.
women can decide for themselves. I think that overwhelmingly the benefits far outweigh the risks. And I think that far too few women are getting treatment. But I would never say that all women.
Not all. It
Have to
depends
be.
upon the precipitating factors, what they have. Oh, is there any link between the obesity, diabetes, all those?
So
High blood pressure.
there is some data that shows improved diabetes in women who are on
Diabetes,
hormones.
yeah.
There's actually improved cardiac health. That's a big thing that we see in women. Contrary to a lot of people think it's bad for their hearts, it's actually good for their hearts. And those are things that you see when we treat women earlier on. And so we can treat women at various ages. I wouldn't say that
Right, yeah.
age is a
The
restricting
precipitating
factor.
factors.
Right.
They might just aggravate it, right?
Exactly.
Yeah.
There's so many things that we have to take into consideration.
Exactly. Obesity, diabetes. How about smoking? Could that be related to perimenopause syndrome?
Well, smoking obviously affects patients in so many ways. And so, women are going to go through menopause with or without the smoking.
Exactly,
But, things exacerbate each other. And so, for a lot of symptoms, they're multifactorial. They're not one thing. We had this vacuum of care for women, and now we're getting better. And you have some people who are kind of flipping to the other edge of saying, hormones fix everything. Well, they don't do everything.
Yeah,
but we
right.
have to do things together. We have to
Together,
fix that foundation so that other treatments are even more effective.
Yeah. So basically, now, what is the difference between vaginal local estrogen therapy and other forms of estrogen, Amy?
So that's a big thing that comes up a lot, because we have all different types of hormone therapy. And one thing that can be really confusing for patients is the difference between local estrogen versus systemic estrogen.
Systemic.
Local estrogen is used in the vagina and vulva, and there's
Right,
different
yeah.
ways that women can use it. It can be a cream, it could be a tablet insert, it could be a ring that's put in once every 3 months, and that provides treatment mainly for what we call the genital urinary syndrome of menopause. We also use it, to be honest, in women who have low estrogen for other reasons. So we see it in women who are lactating and genital urinary syndrome of lactation. And
That was my next question. Can it be used with the lactating women? Because
Yes.
I'm a pediatrician also.
Absolutely. And that is a big spot that it doesn't get used, and people don't know. I know even for myself, after I had my first son, there was a discussion of using it, and the doctor said, well, we could give it to you, but it might hurt your milk supply. And that's
Right,
not
yeah.
accurate.
Okay.
Vaginal estrogen works locally. It helps with vaginal discomfort, dryness. It helps with urinary frequency and urgency.
Right, yeah.
It helps prevent urinary tract infections. It's one of our best defenses against recurrent urinary tract infections, especially in older patients. It can save their lives.
Right, yeah.
And the amount of estrogen that gets absorbed into the body is almost nothing. So
Nothing, yeah.
not only does it not pose any systemic risk, it also doesn't help. So that's where the systemic estrogen comes in.
Right, yeah.
And for systemic estrogen, that can be given all different ways. There's patches, pills, sprays, gels.
So many kinds.
So many different
I was,
ways.
checking, doing my research studies and all that.
Yeah.
There's so many ways now they can give the estrogen.
And that's what makes it such a great option for people, because there are some women that maybe, unfortunately, so many doctors were never trained to do this. They didn't get the training, and so they don't know. And
Right,
so I don't necessarily
exactly.
fault them.
Yeah.
They were never given this knowledge, and so they may have one thing that they use for a patient and it doesn't work well, and then the patient just gives up. Well, we have so many different options and so many different
Right, yeah.
combinations that there's really, very few women who really can't use anything. It's just finding the right fit for that
Finding
patient.
the right fit, yeah.
Yeah.
But there are so many side effects of estrogen too, like precancerous, they say, and more
So-
vaginal bleeding. When you go check with the side reaction,
So-
so many osteoporosis.
Well, actually, it benefits osteoporosis. It
benefits
treats
the-
osteoporosis. And
Okay.
a lot of the things that you see on the side effects, so it just came up in the FDA within just late last year.
FDA approved it.
And the FDA warning labels and a lot of those side effects that you see listed
Right, yeah.
are actually completely incorrect, and they are not based on data. If anything, we have data that says the opposite. And
yeah.
so a lot of women were scared and still are scared to use estrogen because of these supposed side effects.
Right, yeah.
It is common to have some irregular bleeding when you first start some treatment. So patients need to be told that and understand it and not be afraid. As far as risk of cancer, the data actually does not really support that. When we look at, and we can talk more about that later, but there's studies that were done that scared people were then later reevaluated, and that data is not valid.
Yeah, right.
And so the safety is really,
yeah.
very well proven. There's been a lot of studies that look at the safety, and there are side effects. People can have side effects with any medication.
To any medicine, that is true. Yeah, FDA did remove the labels
Yeah.
of some of those estrogen. Yeah,
Yeah.
I read that article, but that happened very recently.
Just
right?
very recent, and it's huge. I mean, the fact that the FDA, this group of amazing doctors went to the FDA and had a roundtable and discussed, and they were able to get that label removed.
Label
and
removed,
just more recently, everybody thinks of estrogen and progesterone. We also use testosterone to treat patients. And right now, there is still a very restricting label for testosterone.
Right,
And they had an FDA roundtable as well about testosterone for men and women.
Testosterone, that's for men though, right?
No, it's not just for men.
It's for men. Women also?
It's also for women, and a lot of women need testosterone,
Really?
and that's
Okay.
such a common thing that people think is, testosterone's just for
It's
for
just
men.
for men.
We have testosterone. We have
Right.
testosterone in our bodies. We rely on testosterone, and that decreases too. So a lot of women need testosterone as well. Estrogen and progesterone aren't necessarily all they
Yeah,
need.
right, yeah.
And the way the labeling works right now, we don't have an FDA approved or commercially available testosterone that's made for women. So we have to
okay.
use the ones that are made for men and then adjust dosing
Okay,
for
so,
women.
yeah, so our people to know who are watching our show, testosterone is available in different doses for women also. It is not just for men, right?
Absolutely. And it's not just that it's available, it's so important
Yeah,
for many
it is
women.
important for many of them. Yeah.
Yeah.
Is there any link? I know so many research and articles have been written about breast cancer and the hormone therapy. Is there any link
So,
with the breast cancer?
so there was a study that called the Women's Health Initiative Study. That was done in around 2002. And that study looked at the primary design of the study was to look at chronic disease in women on hormone therapy.
Yeah, heart disease. Yeah, that's
And
the four
exactly, and
things
heart
I
disease.
read, yeah.
And
Is it heart disease, weight gain? What was the other one? There are four things.
well, they looked at that was the primary design. But what came out initially, to answer your question about the breast cancer, was
Right, yeah.
they used two arms to that study. They had women
Okay.
that were on a synthetic estrogen, which is not really what we use anymore, called conjugated equine estrogen, and the women who had an intact uterus. So those women who had not previously had a hysterectomy were also put on progesterone acetate, or MPA.
Medroxy.
And in that initial evaluation, what scared everybody about
Okay.
breast cancer came from that study, and that was on preliminary results, and it was on those treatments. Years later, there's been post hoc analysis of that same data, and when they looked further, they actually found that the women on estrogen had decreased risk of breast cancer.
Oh, okay. All right.
So we actually have data.
That study is very promising, right?
Absolutely. And so while there may have been some association with the progesterone acetate, that's not what we generally use anymore. That's not even the progestogen that we tend to give patients. And so there's a lot of information that came from that study
From
when
that
evaluated
study,
further,
right, yeah.
that kind of argues against that fear, and that is so often the fear that women have that prevent them from getting
yeah,
treatment.
So, if it is approved breast cancer, this could be used for other kind of cancer too. If somebody has cancer of so many other cancers. I mean, the bottom line is that it is safe to use.
Yes.
Right, with a small dose.
It is safe to use for women who have a family history of breast cancer, other
Yeah,
GYN
yeah.
cancers. It is safe to use for all those women. Now, even women who personally have breast cancer, that's a different category, and that is individualized, and it's a discussion. And there are some women who have breast cancer, especially women who have non-hormone sensitive breast cancers.
Yeah.
They don't have the positive receptors in their cancer that can use
They can
hormone
use the
therapy.
hormone therapy. right.
And it's always a discussion. It's always weighing risks and benefits and shared decision making to decide. And for women who, for some reason, the very, very small minority of women who actually really can't use hormones,
Right.
there are other, non-hormone
Can they
options
use
for
the
some of those patients.
patches?
So
If they cannot use hormone by mouth, or can they use the patches?
for the women who really can't use it, no, they can't use it
No,
at all.
they cannot use
They cannot use it at all.
periods. Okay.
As far as patches versus oral, that comes up a lot when people hear the risk of blood clotting.
Oh,
And
yeah.
so-
I was going to ask you because I see a lot of people with the hormones and they come to the emergency room with the clotting.
And the data shows that transdermal estrogen, so estrogen that is not taken orally, that's given through the skin, whether it be the sprays, gels, patches,
Okay,
does not
gel.
have any increased risk of blood clots.
Okay.
When it's taken orally, what we call the first pass through the liver is what affects our clotting factors and then can promote clotting. even that is not as high of a risk as what people thought. But the transdermal estrogen, which is our most commonly used, does not carry that risk. So women who have some reason to be worried about clotting generally can still have it. If a woman has previously had what we call an unprovoked blood clot, or something that wasn't
Some
due
other
to
cause.
another history, it wasn't due to an injury, it wasn't due to some other underlying reason. They really just out of nowhere had a blood clot or had what we call a pulmonary embolism, where the clot goes to their lungs.
Yeah.
Those people, it's a bigger discussion, and there's different people who have different opinions on that.
That is true.
As
Always
far
a
as the safety.
controversy. Always a controversy, right?
Yeah, yeah. And so, but that's also a big one that we see, that people think they can't have hormones because their mom, their sister, their whoever had a blood clot or something like that.
Is there any link genetic wise? They are trying to figure out, right, a genetic link between all these things happening, blood clots,
Well, blood clots, there
phlebitis.
can be genetic reasons. People can have
Yeah.
underlying,
Like we had
coagulation disorders,
hemophilia,
clotting.
but that
right.
is all treated now.
Right.
Yeah.
You
We
know,
have
there are things-
sickles,
Factor V
sicklers,
Leiden, things like
that
that.
is treated now.
Yeah.
No more sicklers. I remember back in early 2000 when in Children's Hospital used to see so many sicklers, sickle cell disease and
Yeah.
crisis, but now they are all taken
Better
care
managed, yeah. Better identified and managed.
of, identified, right?
Yeah, finding them.
Yeah.
Yeah.
So the science is progressing in every aspect, right?
And as the science progresses, so is the education. I mean,
Education.
that's a lot of, what prevents care is that, like I said, the patients aren't aware. You give a lecture. I was speaking with someone recently who gives talks about menopause to big businesses. And talking about perimenopause. And she said one of the things that's hard is she goes into a company and will offer this lecture for people.
Right.
And the women who are in perimenopause don't know they're in perimenopause
They
and don't know
don't
anything
know.
about it, so they don't even come to the lecture because they don't think it has anything to do with them. They think,
Right.
oh, menopause. I'm only
I'm
40 years
far
old.
before,
I'm far
yeah.
from that.
But they don't know that it is the perimenopause period, right?
And so, the education for the general public, so, things like
Very
this that
important.
really help people, educating our physicians and our other people, we work as a team. I really believe in collaboration. And so last night I spoke with a group of therapists that treat men and women of different ages, and, educating them so that when they're talking to their clients, their patients, and they hear some of these things, they're aware to say, hey, talk to your doctor. Talking with pelvic floor therapists, talking with other specialties within medicine. There's so many people who encounter women through this stage of life, and because we have estrogen receptors throughout our bodies,
Right.
it affects so many different areas.
Right. The
And so-
estrogen receptors, they are all over. And
So being able to have different people out in the community and in the healthcare world
Yeah.
aware to kind of point women to say, hey, you know what? Maybe you should talk to your doctor and get an idea.
So basically, you are spreading the news, right?
Yes.
You are doing such a good job, Amy.
Oh, thank you.
Yeah,
Thank
yeah,
you.
yeah. From a practicing urologist to this field, which is very good, yeah, for you helping the community.
Thank you.
And then, what kind of exercise do you recommend them?
So that's a big piece. Exercise is so important through
Right.
menopause for bone
Yeah.
health and just for overall health during menopause.
Upper body.
Weight training is important. You
Weight
want to
training,
have
yeah,
cardio
yeah.
and weight training. You need a combination, and women are busy.
Osteoporosis
Right.
is always a significant
A significant
factor.
factor.
Osteoporosis, yeah.
And we talk about one thing I heard at a lecture one time, which I thought was a great way of thinking about it, is for women who, women are busy. They have families, they have jobs, etc. How do they fit in a workout?
I know.
And we have to think, you don't have to go out and do an hour-long workout. We can do, what you call little workout or exercise snacks. So you do a 5-minute, workout, or a 5 minutes of squats, or, a 5-minute walk or something when you have time, and then another 5 minutes later, and another 5 minutes later, and that really, allows you to get all those minutes in through the day, and get that exercise. It doesn't have to be an hour-long
Right,
crazy workout.
Yeah. And I know most of the offices, if you work for a big corporations, they all have the exercise availability, right?
Yeah, a lot too, but and also a lot of people are working from home. So at the hour you get up from your desk, you do 5 minutes of squats or push-ups
Squash,
or,
whatever. Yeah.
keep some little hand weights by your
Anything you
desk.
can do,
People have treadmills, get on the
Yeah.
treadmill for 5 minutes. There's a lot of different options. And now, with the internet, obviously you can look
They
up.
can do anything. Watch the internet. So, can you give your last minute keynote advice to your viewers?
I think that for women who are noticing changes in their lives, whether they be physical, mental, psychosocial, sexual, you start noticing a constellation of symptoms, talk to your doctor. Everything isn't menopause, but so many things are related to our hormones, and they can be regulated. And so the important thing is to talk to your doctor. Talk to
your
someone to get more information. And if your doctor isn't lucky enough to have gotten extra training in this, ask
Then
them who
you-
else you can see.
Yeah, right. There's so much of social service platform too. They
Yeah.
can easily reach somebody, like somebody like you,
Yeah.
who can do those telehealth things.
Yeah, and it makes it
Yeah,
really
yeah.
convenient. I mean,
Exactly.
these
yes,
obviously me, I love everybody comes to me, but even other people that offer telehealth, I have
Yeah.
flexibility that I can see people at night, on the weekends.
Right, you can go and
Yeah.
tell this. So I like to thank you, Amy, for coming to my show. I
Thank
like
you.
to thank our viewers for watching me on this show with Amy Prout, and who is a practicing urologist, but her field has now kind of diverted to the menopause and the perimenopause syndrome and the treatment with the hormone.
Yes.
So until I see all of you again, have a very safe and a wonderful spring